See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist, Shauna Butler.
I was doing homeless healthcare, and essentially all my patients also had mental health conditions and substance use disorders, and they all have unmet social needs, namely housing, but food insecurity and transportation barriers. And we were doing a really terrible job caring for that population.
I used to work in critical care in the hospital. I didn't even know that this kind of work was out there.
We were kind of sitting in our silos, taking care of our piece, but people don't exist in pieces. They exist as whole human beings, and that includes their heart disease and their addiction and their wanting a house and a job and their feelings and depression. So we tried to create a care model that would take care of that all together.
Our visits start talking about, do you have everything you need for your dog? And how is your week emotionally? And are you building a community in this new spot? To, okay, you've got these 12 appointments this week. Which ones have you figured out a ride to? How have you been doing on your meds? Are you taking them?
We are intentionally prioritizing some of the most medically complex and vulnerable patients. Too many say are too hard to take care of, like, I can't help Jane. It's too much. Her schizophrenia and her addiction, and she's got all these medical conditions, and she's living under the bridge. Like, how can we possibly help her? We're like, we'll take Jane.
Whenever I hear anyone go, gosh, there's just so much going on with this patient, I'm like, sounds like M3. Send them our way.
We really accompany people.
It's for as long as you need us to get you in a place where you're stable and able to manage these things on your own. We're here for you.
Welcome to See You Now. I'm Shauna Butler. Around the world, our collective mental health and well-being have been faring rather poorly. More people of all ages, backgrounds, and communities report increasing rates of mental health concerns and illness. And for those experiencing chronic homelessness, those mental illnesses are often compounded by chronic medical conditions and substance use disorders. Without safe, permanent housing and access to primary care, those experiencing homelessness and often hopelessness miss needed care, wind up in emergency departments and jails, and never receive the social services that may be available to them. In this episode, we meet members of the M3 team in Austin, Texas, who recognize that caring for people facing the triple threat of chronic homelessness, medical, and mental health conditions requires a high-touch, mobile, and agile approach, one that builds trust and wraps around the person to improve social, mental, and health outcomes.
I'm Tim Mercer. I'm the director of the M3 team. I am an associate professor at the University of Texas at Austin Dell Medical School in their departments of population health and internal medicine. And I direct the global health program for the medical school. And then I'm an internal medicine physician by training, caring for people experiencing homelessness within the Healthcare for the Homeless program at Community Care, which is Austin's community health center network. I went into medicine as my tool for social justice globally. I've lived and worked in Kenya for many years, was sort of brought up in the global health space and care very deeply about and using healthcare to address social justice and global inequities. I'm trying to improve access to care, quality of care, equity in care for vulnerable or otherwise marginalized populations. And so I do that by seeing individual patients one-on-one as a doctor, and then I try to look through their eyes and see the injustices or inequities or problems in the system, and then enact programs like M3 or teaching and mentoring of students or other implementation research to try to improve care models and improve their access to care.
My name is Ashley Sharma. I am the registered nurse for the M3 team at Community Care, and I'm also a stand-up comedian in the great city of Austin, Texas. I used to work in critical care in the hospital, and I graduated 2019, and my first real experience as being a nurse was COVID, and I worked through COVID, and at the tail end of it, I did not like how I felt.
By the time patients got to me in critical care, I felt like I was already saying goodbye and I was more just facilitating them passing. And so I really wanted to move to the preventative side. And as soon as I met Tim and the rest of the M3 team, it really clicked for me. I remember I came out of the interview just being like, wow, that's exactly what I want to do, is work on the preventative side and really get to know these patients. I'm from Austin and I love Austin, and I feel really lucky to get to know a lot of different sides of Austin. From comedy, I get to meet a lot of really great people that I admire and perform at beautiful venues and meet happy, smiling people living here. And then I also get to see the real spectrum of what Austin can be and can hold hands with the people that have fallen through the cracks of this city, and feel lucky to get to know Austin so intimately.
I'm so glad to be talking to you guys today. And one of the things that I love to start with is stories. Tell us about some of the people that you are taking care of currently.
So we see a wide variety of patients. To qualify for the M3 program, we serve patients that are experiencing chronic homelessness, that have chronic medical conditions, chronic mental health conditions, as well as substance use disorder. So we meet people at all areas of their journey. Some people who are neck deep in their substance abuse and mental health problems and haven't really even begun to address any of their social needs. And then we have people on the complete other end that are learning to navigate owning a dog and trying to find work and decorating their house. So we meet like the very basic human needs and then the very, very personable needs as well.
Who did you take care of this week? Who were you checking in on, and what was their situation like?
We have a patient we're going to call Rhonda, who has been with M3 for some time. We call Rhonda our most medically complicated patient of all time, who is young but has a pretty complex medical history. Recently escaped domestic violence. Who's kind of, now that she's safe and overcome her substance use disorder, we're more on the track of learning to manage her medical conditions independently and kind of get back on track, get her some procedures she needs done, as well as transfer from me being the one who manages her medications and appointments and slowly starting to test how much of that responsibility she can handle herself, as well as I talked about the very human needs of keeping a house and making it her own, as well as cooking her meals and finding meals that work with her diagnoses that she can make and can afford the ingredients, and literally building up a wardrobe. So our visits start talking about, do you have everything you need for your dog? And how was your week emotionally? And are you building a community in this new spot? Okay, you've got these 12 appointments this week. Which ones have you figured out a ride to? How have you been doing on your meds? Are you taking them? Have you been checking your vitals at home by yourself? So a little all over the place, but we very much have gotten into a routine of it. So where in an hour we address a whole myriad of things. It's very cool.
Tim, what about you? Who did you see this week?
Well, there's another gentleman, we'll call him Mr. S, and I actually started taking care of him during the early days of the pandemic, and he was sleeping outside. He actually had a truck at the time, so he was mostly sleeping in his truck, and that broke down, and he lost that, and he was sleeping outside, and he struggled with cancer, and he has heart disease and liver disease, and like all M3 patients, a mental health condition and substance use disorder. But we've just sort of accompanied alongside him over the years. And I remember one night of the pandemic, everything was going awry, and his bleeding and his health was deteriorating, and he was living in his truck, and it was unseasonably cold spell here in Texas. And we were really worried about him. We thought he was going to die that night. So we figured out how to get him in a hotel for a couple of nights. And fast forward 2 or 3 years, a lot of things have stabilized. He's gotten through his cancer and it's in remission, and overcome some of his substance use issues, still struggling with drinking and some other things, but is now housed, but then has had some issues with landlord and neighbor and stability of his housing that that affects his health. So, we take that on, and we've been talking with him and reconnecting with his family and figuring out how to get him into a new place. And just last week, he signed his new lease. So now we're helping coordinate his move and kind of staying on top of other things. So that's just another example of, meeting people where they're at in their journey and taking care of the whole person.
So M3, you've mentioned that a couple of times, and it's a healthcare service, it's a medical service, but you just mentioned helping people move, working with a landlord, figuring out transportation, getting a job. So what is M3? Who is that?
Yeah, so the M3 team stands for the Mobile Medical and Mental Health Care Team. We are a interdisciplinary or multidisciplinary group. Institutionally, we're a collaboration between the University of Texas at Austin Dell Medical School, Community Care, which is Austin's largest community health center or federally qualified health center network. So the primary care system in Austin that takes care of the poor and the uninsured or underinsured. And then Integral Care, which is Austin Travis County's local mental health authority. So they're the provider of behavioral health services to the poor and underserved and uninsured. And so the three of us collaborate to really take care of whole person's needs. And it grew out of really a pain point of many of us. On me personally, for example, sitting in clinic, I'm an internal medicine physician, and I'm trained and felt confident treating people's diabetes and heart disease and lung disease or what have you. But I was doing homeless healthcare, and essentially all my patients also, or most of them, had mental health conditions and substance use disorders, and they all have unmet social needs, namely housing, but food insecurity and transportation barriers, et cetera. And we were doing a really terrible job caring for that population. They were falling through the cracks. The burden was on them to navigate it all. We were kind of sitting in our silos, taking care of our piece. But people don't exist in pieces. They exist as whole human beings, and that includes their heart disease and their addiction and their wanting a house and a job and their feelings and depression, all of it wrapped up together. So we tried to create a care model that would take care of that all together and wrap around our patients.
The three M's in there: mobile, medical, and mental. Shouldn't all care actually encompass all of this, that it meets you where you are, that it encompasses your mental, your behavioral, and your physical health? It seems like it should. So Ashley, tell me about the team, and how does this team function?
It's super collaborative, just like you were saying, where it's like, shouldn't all healthcare feel like this? It's funny because it's such a distinct team. And whenever I tell anyone about it, they go, oh my gosh, I've never heard of a job like that. But working in it, it's the most intuitive approach to healthcare that I've ever seen. Like, it just makes sense.
We're all peers and everyone communicates very openly, and there's not one person who is speaking more than anyone else. It's client-centered. So whoever last spoke to the client and best understands their needs at that moment will do the most speaking on their behalf. And we have Tim, who's our medical director. We have me, who is the registered nurse. We have a behavioral health nurse practitioner with Integral Care here in Austin. And then we have several rehabilitation specialists that operate as support and case managers, but maybe with a little bit more flexibility on what they can do. We have a peer support specialist who is someone who has worked through some mental health problems and substance abuse problems in the past, who can meet with our patients to provide emotional support and truly understands where they're at and can provide that close to the issue support. And then we have a housing specialist who is kind of our expert on how housing in Austin works, which is a key piece because all of this is so intertwined. Both of the cases we just talked about, their housing was integral to their mental health and how they address their medical health. And so in the way that all of those are intertwined in that way, the approach should be very collaborative and connected. We also have data specialists from the University of Texas at Austin who run our numbers and figure out what our drivers are and see how we're meeting those goals. And they also uncover the areas we should be addressing. Being a new team, we're really able to uncover new positions we may need and areas that are kind of untapped. We basically go through all of our patients and say, what did we work on last week? What do we want to work on next week? And what's kind of our big picture? And we get everybody's input. So it's really great.
And just to add on, I think that last piece is really important. If you think about it, so much of healthcare is like passive and reactive, right? We sit in our clinics or hospitals and wait for sick people to come to us. And And then we do stuff in the clinic visit, but then it's kind of on the patient to navigate getting their meds or their labs or their specialists or achieving their goals. And we've kind of flipped that around and taken a proactive approach. So these a couple times a week, as Ashley was alluding to, we do what we call roll call. I mean, we basically round on all. We take our entire list and we say everyone's name and we go through one by one and what happened last week or yesterday, today, tomorrow. And so even quote unquote in between the clinic visits, we're proactively addressing their needs, following up on their goals and priorities and getting things done on their behalf. And so that sort of proactive population health management, unfortunately, isn't done very commonly in healthcare, but it's been a real, I think, game changer for us.
Say more about peer support specialists, because I think most of us understand the nursing role, the nurse practitioner, behavioral health, physician, even housing coordinator. That seems pretty clear. But peer support, what is that? What do they do? And how vital is that to the success of M3?
Our current peer support specialist, his name is John, is a person who has lived experience going through all of these challenges, mental health problems, substance abuse problems, medical problems, and have overcome it and found stability in their life. And so their role in our team is to meet our patients, again, literally where they are. He's mobile, just like all of us are. And he goes out and he meets with our patients and he talks with them and relates to them and shares his own experience. And gosh, the feedback we've gotten from some of our patients is incredible. They love John. They feel so heard and understood by John. If there's a patient that I feel stuck on where I feel like, man, I'm really struggling to, I'm really worried about XYZ with this patient and they're not engaging with me very well, or I can feel like maybe they feel like, I don't want to say attacked, but feel nervous about, a nurse is present in their home. I'll schedule a joint appointment with John, and he just has this way of really unlocking our patients and getting them to open up, and they feel so comfortable with him because they know he has lived what they're going through. And John is a super important piece of our team.
And when you say meet people where they are, you mean that quite literally, whether that's in their car, whether that's under a bridge, whether that's on a park bench, whether they've shown up in an emergency department. I mean, you literally are like, give me the address, what's the GPS coordinates, drop me a pin, and I'll be there. How have you convinced people to provide the financial and the logistical support for you to deliver a very high-touch, intensive program?
So we're an integrated care delivery model. We're bringing together primary medical care, behavioral health care for mental health and addiction, and addressing health-related social needs for people experiencing homelessness who have what we call, quote unquote, trimorbidity, chronic medical condition, serious mental illness, and a substance use disorder. So it's integrated through an interdisciplinary staff, through shared communications, collaborative treatment planning, meeting people where they're at, kind of keeping everything in-house. It's truly patient-centered, so mobile, the 3 M's work nice, but sometimes we say mobile and people are like, oh, can I ride along in your bus? Or it's like, we don't have a bus. We're mobile in the sense that we're patient-centered. You described it great. Give me your GPS coordinates and we'll meet you there. So, that's another sort of reaction to, I think, one of the things that's wrong with healthcare. We're so facility-centric. Again, it's like healthcare is designed around us sitting in clinics and hospitals, and we like to say we're facility agnostic. We'll see you under the bridge, we'll meet you on the park bench, we'll come to your house. If it's convenient for you and to come into our clinic, we'll bring you into our clinic, but we'll facilitate the transportation and all that stuff. And we really accompany people. So integrated, patient-centered. We're evidence-based. We're not totally making this stuff up. And so borrowing some evidence-based practices like integrated dual disorder treatment, which is an evidence-based practice that basically says mental health conditions and substance use disorders, when they co-occur in the same individual, which is all of our patients, they should be addressed together, not separately. And those, someone's mental health condition and their substance use disorder have an interactive course where one may drive the other, or they interact with each other, and so we need to be addressing that together, and then further layering on the sort of integration of people's medical and social needs. And locally, we're trying to break down interagencies or interinstitutional barriers and silos that always penalize the patient because they're the one left navigating the fragmented and broken system. And so we're really trying to break that down. So We are intentionally prioritizing some of the most medically complex and vulnerable people in our community. And we want to take responsibility for that niche. Too many say are too hard to take care of, or throw up their hands like, I can't help Jane. It's too much. Her schizophrenia and her addiction, and she's got all these medical conditions and she's living under the bridge. Like, how can we possibly help her? We're like, we'll take Jane.
Whenever I hear anyone go, gosh, there's just so much going on with this patient, I'm like, sounds like M3, send them our way. And we have truly, literally gotten patients enrolled in our program just from hearing someone be like, I'm really frustrated and stuck with this patient. And as they're talking about it, I'm like, checks that box and that one. Oh, we got that one too. And then we're like, yes, and we have them enrolled. So.
And I think we started small and kind of quiet and slow, one by one, and started taking care of these folks. And, now we're sort of in our 5th year of existence. We started this, we got a grant from SAMHSA, the Substance Abuse and Mental Health Services Administration. So a large federal grant to sort of launch this program. And it took about a year to build the infrastructure and the team and the shared data agreements and hire the staff. And then we started enrolling patients, and then a little thing called COVID hit, and we had to adapt and slow enrollment and reorient our care model as everyone did, and then sort of pick back up. And we're still not huge. It's an intensive model, and we don't care for hundreds of patients at any given time, but those we do care for, we care for very deeply and broadly and try to address all their needs. And we've started to move the needle on some outcomes. And now I think we've started to garner the reputation in our community of, that can't help that patient, I'll send them to M3.
Homelessness is something that they're experiencing. It's also something that they can stop experiencing. It also allows for us to not think of our job is finished when they find housing. They're experiencing homelessness, but they're also experiencing a substance abuse disorder, a serious mental health issue, and medical problems. It's like our work is not quite done. One of the really beautiful things that I consider an absolute luxury of this job is that M3 is time unlimited. It's for as long as you need us to get you in a place where you're stable and able to manage these things on your own. We're here for you. As a nurse who hasn't always got to say that to her patients, that's like one of the most beautiful and luxurious things, to really get to hold someone's hand and say, we're not going anywhere.
So mental health, behavioral health, the needs and the challenges across the world, across this country, skyrocketing. We're seeing homelessness rise. So you've got this trifecta of some of the most stigmatized, most under-resourced, complex challenges in there. Tim, Ashley, both of you, can you speak to just the numbers statistically? What do people need to know about the prevalence and the persistence? We'll just start with mental health and behavioral health. What do we know about that?
You're absolutely right, Shauna. It's really been rising over the years. And I think both rising and unmasked. The COVID pandemic laid bare a lot in our society and exacerbated mental health issues and substance use disorders and other inequities in society and in healthcare. For the population experiencing homelessness, depending on what data you look at least half are experiencing a mental health condition and similarly experiencing a substance use disorder. And then specifically this notion of what we call a co-occurring disorder. So that's a mental illness and a substance use disorder existing in the same person is actually fairly rare in the general population. The prevalence of a co-occurring disorder in the general population is like 1% or less. But it's like 60 to 70% in the population experiencing homelessness. So these things often exist together, and then the treatment for that is all too often paralleled and separate. And you really literally hear stories of people with mental illness and addiction, and they walk into the mental health clinic and they're like, oh, I can't help you with your mental health condition until you get your addiction under control. And then they go to the substance use treatment center and they're like, oh, we can't really help you with your addiction because your mental health is uncontrolled. And it's like, these things do not live in a vacuum in their brain, right? So, really addressing them together. So those numbers are quite high in our population, which is one of the reasons was driving the focus of the model.
And Ashley, in part of our discussion, you had mentioned that one of the most important things is that you're person-centered and housing first. And so in order to address any mental health issue, you have to have a place to sleep. You have to have shelter. You have to have warmth. You have to have running water, food, all those things. So say more about this idea of the person-centered housing first and how that really impacts the ability to effectively address somebody's mental health and medical health issues.
We are patient-centered in the sense that we really do have frequent contact with the patient and are frequently asking them, like, what is your goal right now? What is your long-term goal? What's your most pressing goal? And we really do try to center off of what the patients want. For the most part, with our patients experiencing chronic homelessness, that first piece for them is their housing, which makes perfect sense. That can happen pretty quickly with our team. So if we're able to get the patient housed first and have them safe and kind of get them started on having food security and have a voucher that they know is going to keep their housing safe, then we start the more heavy work on like the medical health and some of the mental health problems. But in some cases, patients can't get housed right away, and we are still meeting them in the community.
That's a very polite way of saying under a bridge or
yes, in the
on
community
a park bench.
Is a nice way of saying, like, yeah. Exactly as you said. We've had everything from patients where it's like, okay, you drive down this road and then you're going to see a tree. Park your car by the tree. No one should mess with it. It's gotten that specific like that. Or it's a little more simple. Sometimes it's like, we meet this patient at noon. They like to get a soda from this gas station at noon. So we just sit outside of the gas station. But we've gone everywhere, under bridges, in encampments, at friends' houses, and, wherever we can find them and meet them. I think it kind of levels the playing field. It's already taking a step in building rapport with patients and building trust that we're willing to just be right there. And it's another thing that I really do consider to be a luxury. I've had patients that have injuries, so where they can't even get up and walk to a bus stop or anything. And to say, tell me where you're at, I'll be there, is a really, really beautiful thing.
The flip side of that is again, if it's what the patient wants, we'll be like, how about we pick you up, bring you into our clinic, you hang out in our clinic, we'll get you a cup of coffee and put your feet up, and they'll do a visit with me as the internal medicine physician. The psychiatrist will come over and meet with them, Ashley or maybe John, our peer or our case manager will fill out some paperwork with them, and then we all come to where they're at and they can be inside, out of the elements, and rest, and multiple members of the team will meet with them that way. So we can do it that way too.
So let's get really process oriented from the beginning. How do you find people, or how do they find you? Then how do they get enrolled?
We work closely and really leverage our relationships with other community partners. So both within the institutions that we work, so within community care, the community health center, we have the healthcare for the homeless program, and we have a street medicine team and a mobile team that's part of that. And then Integral Care also has a variety of sort of community-based outreach teams. And then we partner with other homeless service providers, from small local nonprofits to Austin Travis County EMS has a community health paramedic program. So there's lots of our friends and colleagues sort of working out in the streets and taking care of this population. And we've built relationships with them over the years, and now they know about M3. And ideally, what we try to do is have like a warm handoff. So a member of M3 and the patient and whoever's referring that patient, because presumably whoever's referring that patient also has a relationship with them. And so we meet and say, you meet eligibility for services. This is M3. This is kind of what we offer. Do you want our help and our services? And if everything looks good, then we sort of make the handoff and enroll them that way. Then usually those first couple of weeks are fairly intense. We try to get them through meeting multiple of our team members, and we have a fair number of sort of baseline assessments we do. But we really, I think most importantly, is want them to know that, hey, you've got a team in your corner. You've got M3. We've got your back. You need any of us. We have direct lines. We can be directly texted or called. You don't have to, call the front desk and press 9 and press 2 and wait on hold and talk to a stranger. We take care of everything. So don't worry. If a medical issue, you have to call this clinic, or a mental health issue, you have to call that clinic, or it's your Social Security payer housing paperwork, you got to call someone else. No, just call us and we'll help you with it.
So if it's the patient's problem, then it's your problem.
Yes, that is almost exactly our little internal tagline. Like there's no problem that's not our problem.
I remember when I interviewed for this job, I said, can you tell me what a normal day is going to look like for me? And Dr. Mercer laughed and said, I have no idea. It's going to look pretty different every day. That has proven to be true. When I first meet patients, I'll say, hi, I'm Ashley. I'm the nurse. Tell me where you're at just as a person and what your biggest goals are. And I'll kind of tell you what things that set off flags to me, looking at your chart, and let's see what we can work on. And I've gotten answers, everything from like, I need a phone charger, I need an ID, I want a dog, I'm lonely, to I need a pill box, to I need a surgery, to, hey, check this out. And they lift up a Band-Aid and there's a wound that is in dire need of some care. It's everything. And I really, working in the hospital before, never really considered all that goes into getting someone to a medical appointment. But it's all of that. We talked a little bit about what an appointment looks like. A lot of them are uncomfortable in a clinical setting. So it's difficult. They have different levels of tolerance for sitting in a waiting room with other people, previous medical trauma, a tolerance for feeling like they're being watched, a tolerance for waiting. And then in that time, a million other things come up about what's going on at home. My phone isn't charged. I haven't eaten. I don't know how I'm getting home. I don't know how to figure out this. And then we get through the appointment. Then it's getting them home afterwards and then following up on everything we did. What referrals, what medical supplies, what medication changes, when can I see you next to actually deliver these meds and put them in your box? And that's just a day like at the clinic. I also have days where I like schedule everyone for all the referrals and everything. And then it's also communicating with those outside doctors for patients that have a very low tolerance for being in the clinic. I try to go with them to their outside appointments where they may need support. Sometimes I've gone to patients' houses and they're just having a rough day and I'll go, okay, let's put all of medical aside for a second. What can I do for you? Do you need food? Let's go get you some food. Let's sit here and just talk. I had a patient the other day who said, I've been in my house for 3 days. I haven't eaten. I'm feeling claustrophobic. I feel scared to go outside by myself. And I said, well, let's just pack up all the medical. We'll worry about the pill box later. Let's just get you dressed. Let's get you outside. Let's take a walk. Let's get you some food and sit outside and just eat your food and chat. And I think that did more than any medical stuff would have done. So you set a schedule and then nothing goes according to the schedule or the plan. And you just have to be constantly flexible. But I really feel lucky to know that I'm supported by our team's mission and our other team members to where if I go, yeah, we didn't schedule the appointment, but I think we just made some progress on how they were feeling today. And to know I'm supported and have the freedom to do that is really cool. So every day looks different.
As I was doing some research about M3, it being team-based, housing first, trauma-informed, recovery-oriented. And one of the key pieces that I have not seen is one of the goals also is to interrupt inequity. How does a model like M3, if your goal is to interrupt inequity, what are those inequities and how are you interrupting them?
Homelessness is a consequence, the end of the road of sort of inequity in our society when it comes to everything from education to our criminal justice system to housing affordability and costs and economic opportunity. We also know that there's racial inequities that drive homelessness, and in every single state in this country, Black people are disproportionately represented in the homeless population. So let's just take Austin, for example. 9% of the general population in Austin identifies as Black, whereas 32% of the population experiencing homelessness identify as Black. And that's not unique. As I said, we see that essentially in every city, in every state in the country. And so we've taken an intentional approach to that, of recognizing that people identifying as Black are disproportionately likely to be homeless. And we can't fix all of that with the M3 team, but we can take one small intentional step towards that of recognizing it, of number one, training, making sure we're all aware of it and we discuss that and we train our staff on that. Number two, we make sure we disaggregate our data and look at our outcomes, both our final outcome measures, but even our process measures. And we try to look at that by race. Is there implicit bias? Are we treating our Black clients different than our white? Are there differences in outcome? And if so, why? And we talk about that very openly as a team. And then thirdly, we talked about the eligibility criteria earlier, but all else being equal, we are intentionally prioritizing the enrollment of African Americans onto the M3 team. So right now, about 40% of those enrolled on on the M3 team identify as Black. And that's our one way in which we're trying to disrupt that inequity.
How common or uncommon is this M3 model?
Well, I guess I will say it's not common enough because the need is certainly greater than, again, just here locally, we have a wait list of referrals. So in that sense, we're not keeping up, right? Like homelessness is rising in this country. It's rising in our city. Inequities are widening and rising. The burden of mental health and substance abuse is rising. The population is aging and people are accruing more chronic medical conditions. And we know the homeless population is also aging. So in that sense, there needs to be more of this. We're certainly not the only people with a model like this, but most is sort of passive and reactive. Healthcare systems built around us as providers. You got to wait in line, make an appointment, don't be late, register in the portal ahead of time, give notice, all the things, all the barriers, and then you get seen and we get a 10 to 15 minute visit in a typical primary care practice, or maybe half an hour, and seen again in a few months. And again, there's not a lot of in-between work. So I think in that sense, we're pretty unique.
Talk about some of the successes that you guys are seeing. What are some of the really exciting data points when you've got this data team? You have a partnership with an academic center that's doing research, because in order for us to pivot to a lot more of these models, there needs to be the data that says this works, and it actually works better than the prevailing system. So what are some of the wins, and what's it going to take for there to be a broader adoption so that there are more teams and they are more expanded?
But I'll speak to a couple of things that I know that we've, like a couple of our drivers that I know we've really improved on. And then Tim just finished submitting our grant to extend our funding from 2023 to 2028. One big one is right now within our team, we're 75% housed, which means 75% of our clients are actually in housing right now, which we never feel more than when it's like, wow, it's really hot out today. And once you start doing this kind of work, whatever the weather is, you immediately think of who does not have a roof over their head right now. And it really helps when instead of trying to get 50% or 75% of our patients last minute shelters when the weather's obscenely hot or cold or rainy, we get to go, oh, we only need to find 25%. And recently when we've had inclement weather, we've been able to do so certainly easier than we have in the past, just because so few of our current patients are actually unhoused, which is a great feeling. And then to speak to the emergency services driver, one big goal is to reduce the amount of unnecessary EMS calls and ER visits and increase the amount of appropriate ones where that is actually what the patient needed, and that through that visit, they were able to get what they needed. Gosh, I remember one time I saw a patient every week, and then I was like, let's try seeing each other every 2 weeks. And in that 2 weeks, they went to the ER 6 different times. And then we've had clients that were going multiple times a day, bouncing around ER to ER. Man, I don't think we have anyone who is going to the ER that frequently anymore. And I think finding those intermediate resources, being an intermediate resource, and educating are the 3 ways that M3 really addresses that.
So Tim, you've been deep in the data and the evidence justifying why this grant should be extended. And you talked about that there are wraparound services, or that you're helping people, whatever problem they have, you need to help them fix. So I would imagine that's getting SNAP benefits, it's housing benefits,
Yep.
Transportation. So in terms of the wins, like what have you guys been able to achieve in helping people make progress in becoming more connected back to the community and getting the resources that they need?
Number one, I would just echo a huge success that we actually didn't totally anticipate was our success in navigating people into housing. As Ashley said, it ebbs and flows a little as we enroll new people. When you start on the M3, by definition, you're homeless and out, not housed. That drives the numbers down. And then as they are on our team, we've been quite successful, 75% thereabouts of navigating people into housing. And we don't have any actual dedicated housing dollars, or getting enrolled on M3. We don't have any housing vouchers allocated to us per se. That's just dogged case management and accompaniment and dotting all the I's and crossing all the T's of all the forms and paperwork and everything it requires to get a house our housing voucher into housing for folks, and building the relationships with the various housing and community partners in our community to make that work. And then we don't just discharge them or hand them off after housing, kind of continue to follow them in and address their needs and keep that stable. So that is huge. And from a housing first perspective, from a housing is healthcare and a human rights perspective, which I think we all embody, that's really important to us. And as Ashley mentioned before, it's often our clients' number one priority. We've been quite successful in addressing other social determinants of health. So 100%, every single person enrolled on M3 has some sort of health coverage. Texas is one of 10 or 11, I think one of 10 states that has not expanded Medicaid. So health coverage is not available or guaranteed here. Around 80% are a little bit more enrolled in SNAP benefits, so addressing food insecurity. About 42%, I believe, we've got enrolled in some sort of Social Security or disability income, some through the SOAR program, some through the traditional route. We would argue that probably the majority, if not all, of our clients are eligible for Social Security disability benefits, given their multimorbidity, but that's a very long, slow, bureaucratic, tough process. But we, help them with that, those applications, walk alongside them and help facilitate that, which is huge because that then opens the door to income and Medicaid and additional housing options. So we're really working pretty hard on all these health-related social needs and social determinants. In terms of mental health, we're using some validated measures that we measure at baseline and then in 6-month intervals. And we've seen significant reductions in depression symptoms and improvement in functioning, significant reductions in scores on subscales related to self-harm. And so really moving the needle on some of the behavioral health symptoms. And then, as Ashley mentioned, about a 50% reduction in emergency department visits. We've looked 6 and 12 months prior to enrollment on the M3 team and then 6 and 12 months after, and have seen significant reductions there. And then also about a 50% reduction in ER visits specifically for a mental health admitting diagnosis, so for mental health crises. I do think it is important to say again, Ashley's already said it, but that we're a little bit obsessed in healthcare with reducing costs, and that's only tells part of the story. So we are reducing ER visits and therefore most likely saving costs. But I've got some patients that I'd love to get into the ER, into the hospital, if we could only get them to go. And so not all utilization is bad.
We were just talking about data and the impact that M3, the model, is having on patients and people in the community. There's also another set of really alarming data about the number of people who are wanting to leave the healthcare workforce, don't want to be in healthcare anymore because all the things that your patients are experiencing, healthcare professionals are experiencing as well. They find the frustration and the moral distress of not being able to get people the care that they need and that they deserve. So how does working in this model help you to stay in your careers, want you to thrive in your career, and then take care of your own mental health and well-being?
I loved my work in the hospital. I was very interested by it. I felt passionate about it when I was there, but I really did. It was like overnight. I hit this like total burnout where I just felt like I couldn't be there for even a second longer because I just felt completely helpless to help my patients. Once they were in critical care, it felt impossible to help them in any way other than like kind of fixing the immediate issue and then sending them on their way, knowing that they didn't have the social and outside support to help them thrive long term. And I truly was at a breaking point when I interviewed for M3, and I was so disenchanted by healthcare as a whole. And I didn't even know that this kind of work was out there. And I feel the days can be equally as hard. It can be sometimes day to day, it can be equally as heartbreaking. And I'm not saying that it's easy, but being on this side, the preventative side, being on the side that provides the social supports to stop patients from having to end up in that critical care unit, in their last days, it gives me so much more peace at the end of the day to go, we did something to keep them from getting to that point. That has done immeasurable things for my own mental health. I was like, all right, comedy better take off tomorrow because I'm done. Being on M3 has made all the difference.
And what about your mental health, Tim?
Yeah. There are moments or days or times when I can get really angry at our healthcare system for the way it treats the poor, or other minorities for the way it's unequally distributed and works better for others, those with means, and all just the barriers and challenges my patients face. M3 is working against all of those things and is an antidote to that. And so I think that's what keeps me going and gives us hope.
Ashley, what are you seeing the nurses' role in helping to improve mental health or to develop models so that we can reach people and move further upstream? Because I feel like so much of what we're doing is just really late. It's the hardest part of the problem. It's the most expensive part of the problem. And it seems like we should be moving further upstream a lot faster.
It's kind of twofold, and I think they both tie into M3 and why I feel so lucky to be in this program is, one is getting to break down that barrier and kind of move away from clinic only, facility only care. I feel like I have a very strong rapport with my patients, and I feel like I am a big part in helping them care for their mental health because they trust me to do so. And I feel like a lot of that trust comes from getting to break down that barrier of just meeting them in the clinic and truly meeting them where they are in the physical and abstract meaning of that. Number one for nurses is finding a way to get around those barriers and break those down to see people in the community and meet them where they are.
You know, the typical business of healthcare isn't working for this population, so let's do things differently and take the time. And I mean, I think it really comes down to, it's about accompaniment. We sit with our patients, we sit with them. Sometimes that's all we do. We sit with them and hear them and listen to them and walk alongside them and don't disappear.
Special thanks to nurse Ashley Sharma and physician Tim Mercer and the entire M3 team in Austin, Texas, for sharing their learnings, successes, processes, challenges, and commitment to a person-centered housing-first approach for Austinites experiencing chronic homelessness alongside chronic medical and mental health conditions. Mental health impacts our communities in so many ways. Among individuals experiencing housing insecurity, 21% have a serious mental health condition. 1 out of every 8 emergency department visits involves a mental health or substance use disorder. Severe mental health conditions cost the U.S. economy $193 billion in lost revenue. The numbers and stories are powerful tools for raising public awareness, stigma busting, and advocating for better ways to deliver the full range of care people need to thrive in their lives. The U.S. has long faced a shortage of mental health providers. It takes an average of 11 years to get treatment after the onset of symptoms, and less than half of Americans struggling with mental illness ever receive the care they need. And this is especially true in rural and other underserved communities like those experiencing homelessness. Meeting and accompanying people and providing wraparound support increases the connection with more social and mental health resources. And this helps people use those resources appropriately and eases the strain on our health systems overall. As both Ashley and Tim note, increasing the number of appropriate visits to hospitals, emergency departments, and primary care is actually a measure of success. When it comes to caring for the medical and mental health of those experiencing homelessness, as Tim shares, people don't live their lives in pieces. Housing, medical, social, mental, and behavioral needs aren't separate experiences that can be effectively addressed and well managed in fragmented, difficult to navigate, independent systems. Integrated, high-touch care is how people move into and remain in permanent housing, improve their physical and mental health, meet their goals, and thrive in their lives and relationships. It means listening, walking alongside, not disappearing, and instead, meeting people where they are, wherever that may be. For See You Now, I'm Shauna Butler. Thanks for listening.
Nurses are transforming healthcare. through innovation, compassion, and leadership. And Johnson & Johnson is proud to continue its 125-year commitment to champion nurses through recognition, skill building, leadership development, and more. The American Nurses Association is dedicated to building a culture of innovation. Nurses improve the lives of patients and communities through innovative thinking, empathetic connection, scientific rigor, and sheer determination. ANA is proud to support and advocate for our nation's most valuable healthcare resource, our nurses. For more information on See You Now and to listen to any of the earlier episodes in our library, visit seeyounowpodcast.com.